Even though it is Columbus Day next Monday, there will be a speaker, so do tune in. So I am so incredibly happy to introduce Dr. Pamela Stone. Pam Stone is a biological anthropologist who got her PhD in 2020 with a thesis entitled Paleo-Obstetrics, Reproduction, Workload, and Mortality. She has stuck with this topic and many others related to women's health, indigenous health, and the mother-infant nexus. Her approach is biocultural, and she uses methods from bioarchaeology and forensics. This has resulted in several books, the most recent in 2020 entitled Bodies and Lives in Victorian England, Sex, Science, and the Affiliation of Being Female. And she has an edited volume from 2018 entitled Bioarchaeological Analyses of Bodies, New Ways of Knowing Anatomical and Skeletal Collections. In 2016, she had a yearbook of physical anthropology review paper on biocultural perspectives on maternal mortality and obstetrical death. Dr. Stone is currently teaching at Mount Holyoke College in Amherst, Massachusetts. As a side note, I was Pam's undergraduate, MA, and PhD supervisor, and we have been collaborating and publishing and having grand adventures for over 30 years. And she's a co-PI on the NSF-funded Berlin Cemetery Project, which we will be working on for the next 3 summers. I'm so honored that she agreed to come and give this talk. Please give a warm welcome to Dr. Stone. Okay, Pam?
Okay, can you hear me?
See you? Are you?
Yeah, I'm here. Can you hear me?
Okay. Yeah, now I can.
Okay, you can hear me. I think
Okay.
Esther is in charge of that. So thank you, Deb, for that introduction. Just one clarification, my PhD was 2000, not 2020.
Oh God, yeah, I said 2020. It's 2000. Sorry, everyone.
That's
21
all right.
years ago. 21 years ago. All right.
And thank you for having me. By way of introduction, I also wanted to share with you a little bit about my scholarship from my perspective, which began as the Native American Graves Protection and Repatriation Act was being debated and ultimately voted into law. This moment changed the playing field for physical anthropology and how studies on human remains were to be conducted, or if they were to be conducted at all, by bringing in the descendant communities to consult and decide the fate of their ancestors. While this seems like a no-brainer to me, it was a heated and contested moment within anthropology, and this gave me pause, challenging me to consider if I want to continue in a praxis that colonized and othered people, any people, with a single paradigm that this work was for everyone. This paradigm promoted a Western scientific empirical perspective, a perspective at the time didn't seem to see the value in other perspectives and ways of knowing. While today this is not a popular position, it was a position of many physical anthropologists of the time, and it really didn't sit well with me. But this was also a turning point for me, one where I understood that anthropology and anthropologists needed to be more inclusive as well as self-reflexive, and to consider other perspectives and experiences. And while that seems obvious, it was a bit blurred at the time. Since this time, I have worked to understand the complex interplay of science, culture, and lived experiences, particularly in the context of the female body and reproduction. My inquiries have spanned direct skeletal analyses, cultural explorations of birth practices, understanding the history of medical culture and context of social ideas, eugenics and race science, alongside the impact of racial disparities on health and wellness, among a myriad of other lines of inquiry. But the heart of my work has been an exploration of childbirth, something I see as a human universal, something that biologically occurs in the same way across cultures, geography, and time, but culturally it's experienced very differently. And yet, today, there seems to be a singular lens through which we try to understand the birth process, the biomedical Western white lab coat lens, a paradigm that promotes a single Western scientific empirical perspective. And ironically, that's the same flaw I saw in the way in which anthropologists were thinking about their work in a pre-NAGPRA time. Amazingly, our understandings of pregnancy and birth continue to be tied to this single ethos. Over the years, I have researched, listened, and experienced and considered the complex frameworks of being pregnant, of going into labor, giving birth, postpartum, and parenting. I have also given birth twice. I have also been mansplained by white lab-coated doctors and educators, as we see in this response to me via email, where this medical doctor is telling me how his evidence-based practices and how science in the delivery room is used, quote, in the best way possible, striving to strip away bias and cultural subjectivity. Clearly, this has absolved these medical practitioners of their roles in creating disparities because they are working through the lens of empirical science and thus not complicit in racializing the reproductive and birthing body. Or there is a need to consider the experiences of the person giving birth. To them, birth is a medical event, and they are doing a great job in managing it. In contrast, my research has been embraced by expectant mothers, midwives, doulas, and people thinking about their potential reproduction. I have called to action the need to consider how different cultures have created spaces for birth to happen, bodies to be respected, and mothers and babies to survive and thrive. Okay, so what does this all mean, and where does that take me and us today? For me, it means that the human experience is complicated. There's no one size fits all. As an anthropologist, I believe my research needs to consider a vast array of historical, cultural, social, personal, biological, and authoritative ways of knowing in order to unveil existing systems of inequality. In childbirth, anthropology, medicine, and science all have offered single narratives that continue to shape and hold the reproductive female body in shackles. Yes, I said shackles, because while it's obvious that it's inhumane to force an incarcerated woman to be shackled to her bed as she gives birth, we don't seem to consider the other ways in which the birthing body is shackled to the medical system. We often neglect to consider disparities of care and access to birth options that are embedded in the culture of obstetrics and transcribed onto the birthing body by biomedicine structures. So my goal here today is for us to briefly consider the ways in which risk narratives surrounding childbirth are culturally constructed, controlled by a restrictive set of inflexible measurements, and how these frameworks serve to and continue to devalue the physiological experiences of birth, while framing the female body as in need of medical care, which in turn also produces and reproduces reproductive privileges for white females. I will conclude here by highlighting how my work engages a critical white feminist lens as I explore the ways in which childbirth and the reproductive female body continues to be shackled by a colonial white practice that values white middle and upper class female bodies while devaluing all others. To unpack risk narratives, we need to explore how the concept that childbirth is the riskiest moment in a mother and child's life arrived within our collective understanding. This is the meta-narrative that I hear over and over. And as we see, it is this narrative of the medical doctor who found the need to explain to me how wrong I was. But what was at the root of this? I often note to my students, if childbirth was so risky, why are there so many people on the planet? Of course, the rote response is because medical support. More babies and mothers survive. Thank God for modern medicine. But is this true? And then why does the US have such a problematic maternal mortality statistic? So let's explore the idea of childbirth risk narrative and how it may have developed by looking at some of the historic and well-documented pathologies that come from the marriage of childbirth and biomedicine. To begin, we need to consider that the rise of Western medical sciences in the 1800s is framed by the tensions between ideas about evolutionary thought and the acknowledgement that civil society was God-fearing, white, and more evolved than all others. For childbirth, this meant that it was imperative to shift birth away from the hearth and home and out of the hands of the unlearned and dirty female midwife and into the hands of the learned and clean and civilized male practitioner. New methods of quantifying maternal death in the mid-1800s gave rise to models of care that required parchment women to be moved into controlled clinical settings. These models of care worked to create an assumed need for the management of birth. the goals of which were to separate the female from her reproductive body, constructing an image of birth that requires skilled and formally educated intervention and support. These new models neglected to explore the intuitive knowledge and physiological processes that have made birth possible for females repeatedly for centuries, if not millennium. The image created is one of illness. This assumption of reproduction as illness affects how risk is understood in biomedical and childbirth narratives. Prehistorically and historically, there is little direct physical data to support the Western pathologized picture of risky birth when birth is considered outside of Western medical culture. For example, Engelman, a medical doctor, conducted an ethnological study of birth in non-Western cultures and offers strong testimony about the lack of obstructed or dangerous labors for non-whites, or in his words, the other races. In the archaeological and paleopathological research, demographic analyses suggest that reproductive age women were more likely to present in skeletal and cemetery samples, but there's often little tying these deaths directly to childbirth. Yet these deaths are always assumed to be the result of reproductive complications. This assumption is girded by the Western biomedical framing of birth, in which we are constantly reminded that pregnancy and birth has a long and dangerous prehistory. But what direct evidence exists that females in the ancient world, in their peak reproductive years, died as a result of childbirth complications? The few researchers that have employed direct clinical pelvic metrics on prehistoric skeletal samples seen here, and I'm going to show some data, so it's a little crazy, but all reveal the dimensions of the pelvis that fall within or very close to normal sizes. So these are their data against the backdrop of the US normal size set by obstetricians here in the US. These data counter many of the assumptions of reproductive complications of the pelvis. Through these data, it can be considered that birth took a very similar path biologically in the ancient world, and that something about culture may have put young females at risk for early death. And pregnancy and childbirth most likely added additional strain, but they may not have been why they died. When we frame maternal mortality within historical contexts, the same adage is replayed. Females who died during their peak reproductive years did so as a result of pregnancy-related complications. While ethnographic examples of the success of historic midwives in their practices are few, as females rarely kept written records, there is one diary that exists kept by Martha Ballard, a midwife who practiced on the frontiers of Maine from 1785 to 1812. Her diary provides records for all the births she attended during this 27-year period. Of the 800 births she records, she did not lose a single mother or child to childbirth death. However, she does record the shift in care as medicine and men began to take over birth and parturient females begin to expect medical interventions. While the texts and diaries are few and far between, the clinical and social frameworks of pregnancy and birth can also be examined in the historic context through other forms of documentation. For example, data on pre-industrial Europe reveals lower than suggested maternal deaths before medicine's interventions. The Royal Medical Society in Great Britain documented childbirth deaths between 1752 and 1781, revealing that there was less than 1% of maternal death rates over those 30 years. French statistics reported even lower death rates, so below 0.5%, in Paris from 1740 to 1742. For both, the majority of these births were home births, and those who died were noted as being taken directly from their homes to the churchyard. But as more females delivered in lying-in hospitals, there is an alarming increase in the rates of infections, fevers, hemorrhages, and childbed deaths, which marks the 19th century of one of the highest maternal mortality rates. By the mid-19th century, the rates of maternal morbidity and mortality began to rise steadily. Interestingly, the females most affected were those accessing medical care for labor and delivery. They were white, affluent, and Christian. Females from other cultures were not seen to have the same childbearing issues, and it becomes clear that high rates of death in childbirth is not a species-wide issue, but temporally and culturally specific product of Victorian era lifestyles and expectations to use medical care and spaces, which seems to create the greater risk for morbidity and consequently mortality. These are the frameworks that created the scaffolding for current models and physical assessments of risk of death in childbirth today. But why? What is it about these Victorian females, you might want to ask? You may be thinking, how can this not be species-wide? Why am I always hearing about the human pelvis is just too small for big brain babies we bear? Is there actually something biological, skeletal, evolutionary going on? These are all great questions, and I'm going to explore them a little bit. So, the human pelvis. The first step in understanding something about the idea of a too small pelvis requires us to first consider the pelvis. We need to see how it was examined by early anthropologists and medical men to get our first glimpse into how cultural frameworks are rooted within biological analysis. To start, let's look at the work around sexually dimorphic pelvic structures, which was a central focus of typological analyses and racial classifications in the late 19th and early 20th century. The goals of which were to show that there were both polygenetic and clear racial markers that denoted differences between the sexes, males and females, as well as by race within the sexes. By the mid-20th century, anthropologists like Schultz, Krogman, and Washburn believed that they could frame evolutionary shift to bipedalism and the encephalization of neonatal heads as a scar of evolution or an obstetrical dilemma that females must bear. There it is, sorry. They were able to make a compelling case that the failed relationship of the female bipedal pelvis to neonatal cranial size was at the heart of the maternal mortality issues of the time. In Krogman's words, there can be no doubt that many of the obstetrical problems of Mrs. H. sapien are due to the combinations of a narrow pelvis and a bigger head in the species. This 20th century fact of life becomes entrenched in biomedical obstetrics, anthropology, and in the eyes of the public. Females were now seen as being held captive by their difficult and dangerous reproductive situations. Never was the system that ultimately placed the partridge in the medical arena questioned about its role in the dramatic increase in maternal mortality. So let's be clear, the evolutionary shift to bipedalism did change the morphology of the birth canal. It did make it smaller as compared to our primate relatives and ancestors. But evolution also acted on the neonate. Research by Dunsworth strongly suggests that combined human pelvic dimensions have been selected to accommodate neonatal dimensions. So while a tighter looking relationship between the neonatal head and the birth canal is evident, there are also other physiological processes in place to make sure that the mother and neonate can survive labor and birth. But this would be another talk. But consider that there are hormones, and of course, the birth position can also play an integral role in successful outcomes. So you'll have to invite Holly to come and talk about it, or I can do another talk one day. But for now, let's think about the fact that the female body may not be scarred, and consider how do we measure the pelvis to see how changes may or may not have impacted birth, and what do we learn? So, why is this not going? Anthropometric measurements of what is known as the, I'm one slide ahead for some reason. Okay. Anthropometric measurements of what is known as the true obstetric pelvis includes the portion of the pelvis lying below and including the pelvic brim, which represents the area of significance since it includes the bony canal through which the fetus must pass. So just to be clear, the concept of birthing hips is a fallacy, as the measurements of the ilia, or the false pelvis, as you can see here, which make up the structural frameworks of your hips, is not related to size or shape of the true pelvis, unless someone has suffered major trauma to the pelvis, and then it might impact the size and shape. But your size of your hips do not affect the size of your true pelvis. So in order to understand how the bony pelvis relates to childbirth, my measurements, and hopefully those that are also doing these in the field, and there are not that many, follow the 3 functional planes used in childbirth to denote the progression of the neonate in birth. As you can see here, and the images on the slide are correlated with the movement of the neonate as they ascend the birth canal, which is measured in stages, which actually start from 5 and go to 0, and then it's 0 to -5. And this is the way in which they talk about babies as they come out of the birth canal. The measurements taken on the bony pelvis can also be correlated to those on a living person by a provider, so a midwife, a nurse, an obstetric nurse, an obstetric doctor. These are used to describe what we call a normal pelvis and include pelvic inlet, the mid-pelvis, and the outlet. And I'm only going to focus on the inlet here because this is the area of most obstetric interest in relationship to parturition, because if inlet contracture can result in prolonged and unprogressive labor, since clearly the fetal head can't descend and get into the birth canal. The pelvic inlet is considered contracted if its shortest anterior posterior, so front to back diameter, is less than 10 centimeters, or if its greater transverse diameter is less than 12 centimeters. And this is approximated manually, as you can see here in this image, during a prenatal exam by measuring a diagonal conjugate and adding 1.5 centimeters. A contracted inlet is indicated when the diagonal conjugate is 11.5 centimeters or less, and a cesarean delivery will be scheduled. So unfortunately, these measures are static and don't take into consideration the broad range of hormonal changes or the delivery position of the parturient female either. All of these have potential to enhance the pelvic breadth and allow for safe delivery without intervention. Once again, variability is lost and females are tied to a rigid standard that dictates the path of birth beyond the cultural and biological buffers that may assist them in delivering without surgical intervention. If we consider the measurements in concert with what we know now about pelvic architecture, we begin to have a formula to consider how lifestyle, health, and other external factors impact successful childbirth. Further research in the last 30 years has demonstrated that the overall dimensions of the adult female pelvis are reflexive of a complex history of heredity and environmental interactions. We know that the development of the pelvis, and especially the full development of the birth canal, is affected by nutrition, disease, and other problems, all of which, when compromised, can cause reduction in the size of the pelvis. These studies have brought to light the importance of including a number of factors such as age, growth, and development, and environmental, occupational, nutritional stressors into consideration when assessing the relationship of a critical dimensions to maternal mortality. Yet a flattened pelvic inlet shape in the most extreme form seems only to be reported from the 19th century. During this period, this type of contracture was seen as the complete disfigurement of the pelvic girdle, making it look something like a figure 8 as seen here. With this type of extreme contraction, it represents a common problem seen in the 18th and 19th century Europe, but we rarely see it in other contexts across time and geography. In fact, I have never seen it in any other context. But it underlies our risk narratives framed around evolutionary assumptions that are focused on the pelvis. As we explore the data, it becomes clear that the expectations of lifestyle for Victorian females, coupled with Victorian ideas of evolution, as well as the environmental and labor consequences of the Industrial Revolution, resulted in a confluence of issues that impacted female health and pelvic shape for the rich and poor. So let's explore a couple of these elements of Victorian culture and how these things may have influenced childbirth. If my computer will do it. It is important to remember that the Victorian period, I think I skipped, sorry. It is important to remember that the Victorian period marked British expansion across the globe, and with this, new cultures and people came under the lens of scientific analysis. Victorian scientists saw those outside of their insular white European communities as objects of study. Race became a central tenet in the movement to civilize, colonize, and otherwise distinguish white British citizens from all others. Victorian females were set against a racial hierarchy in which they were deemed less than their white male counterparts, but greater than all others. Conceptions of normative citizenship were entrenched in the ideologies that constructed race as a biological concept, colonialism as central to the civilizing mission, and norms for behavior must be understood within the social and ideological context of British imperialism and its effects on Victorian codes of morality and scientific inquiry. The Industrial Revolution, which aligns with the Victorian period, also had a dramatic impact on the lived experience. Societal transformations caused by introductions of new technologies in all areas of production, from farm to factory, and for our purposes within medicine, were seen as creating greater efficiency. Industrialization also had a dramatic effect on people's lives and health. The long hours, poor working conditions, and polluted skies that were characteristic of the industrial capitalism and especially factory work, despite increased social mobility, greater leisure, and improvements to education and medicine, saw females across all classes suffering from both direct and indirect effects of increasingly industrialized and urbanized environments. At the height of the Victorian era, it has been documented that most children were suffering from record high levels of chronic childhood rickets, the result of a lack of vitamin D from a decrease in sun exposure as a result of pollution, as well as undernourishment. All classes of children were impacted. Poor children labored in the factories, and increasing rates of poverty also placed many at risk for malnutrition. For the middle and upper classes, Victorian moral codes not only required proper girls to keep out of the sun, but to stay thin and fragile, contributing to their own cycle of poor nutrition. When we think of females from the Victorian era, one thing that often stands out is the style of dress, and more specifically, the use of the corset and the tiny waist that many tried to maintain. While the height of fashion was to have a well-fitted corset and for young women to have a small waist, the health consequences of the corset did not go unnoticed and were debated within the medical establishment, focusing on the displacement of the internal organs, especially the lungs and bladder. In the late 19th century, X-rays were used to reveal the displacement of the lower ribs, also known as the floating ribs, which were squeezed in and up while the vertebral articulations and spinal processes pushed down. In addition, the pelvis would be pushed in by the corset and pulled down by the weight of the skirts, resulting in a figure eight or flattened pelvis. In contrast, society females wishing to produce proper daughters saw the corset as a positive tool to control the bodies of young females. Corset use accompanied by restricted eating made these females more susceptible to fainting and other afflictions associated with the fragile female, as they were literally having the breath squeezed out of their bodies, all of which reinforced cultural assumptions of females as a weaker, more fragile sex, especially for middle and upper class white females. As noted too, it was a time where children were suffering high rates of rickets combined with the cultural expectations of not to eat too much. Affluent female children were more likely to have the smallest waists, as this was a sign of status. With rickets and tight lacing, the Victorian body project was achievable. We can see here in this X-ray the direct impact of the pelvis as a result of extreme rickets. Here, where the bones are softened by rickets, and then you can imagine lacing them into a corset would result in an even more flattening of the birth canal from front to back, resulting again in this beautifully small waist and the worst type of pelvic deformation you could have, the figure eight pelvic shape, and certain death in childbirth. Statistical data on obstructed labor for this period reflects that dramatic increase in obstructed labor due to a flattened pelvis. So the Victorian era marks not only the period in which a flattened figure eight pelvis is reported, the expectations of beauty and motherhood and the reported high rates of rickets are clearly indicated in the dramatic increases in maternal and infant mortality of the time. From infections to obstructed labor, while white elite Victorian females had the right to be scared, childbirth was the riskiest thing they could do at this time. But what does this tell us about today, about risk narratives in childbirth? Computer does not. Yeah, sorry, my computer keeps skipping. While I have not done as deep a dive as I could, we can start to see how Victorian era culture frameworks intricately woven into the ways early medical practitioners and scientists were seeing female bodies in regards to reproduction. I believe these culturally constructed frameworks are pivotal to our understanding of how science and subsequently, anthropological studies come to frame the concept of the normal reproductive body, and that prescribed medical support for all birth perpetuates from this framing without interrogation. What we call a normal reproductive body today is a product of Victorian social systems that constructed it, a white male system that saw the rest of the world as less significant, and a white female system that subscribed to the social performance and expectations scripted for them. Combined, their actions create a platform that all bodies are measured. By failing to recognize the ways in which 19th century colonial science shaped our understanding of the human experience, we are complicit in reproducing the same flaws, and we will miss much of the complexity of being human. The normal reproductive female body hinges on the narrative of the weak and fragile female that's deeply rooted in this Victorian era social controls, colonial practices, and the development of race science. It's also predicated on the cultural performance of beauty for the economically secure and obviously white female, without consideration of the resilient, unbound female body in all other contexts. The construction of the normal reproductive female is also assumed to be civilized and evolved, which are culturally contingent, biologically deterministic, racist, and sexist scaffolds, positioning female reproductive bodies without considering the social expectations that created and reinforced these behaviors that influence these biological experiences. White anthropologists and feminists need to consider how this narrative persists and has served to devalue non-white female bodies. We need to bring forward the participation of white males and females who continue to implicitly uphold these standards as rigid current norms. And something just happened. Sorry. Can't tell what slide number I'm on. So until the deeply seated white practices of the 19th century and engage with a lens that is reflective, recognizes the complexity of historic narratives of direct and indirect cultural violence and the influences over females, how females continue to be assessed. Clearly, historically, there were a confluence of issues that resulted in Victorian white middle and upper class females to have very complicated and yes, risky childbirths. But as I've discussed here, there was a moment in time, not a product of human evolution and not something that would result in risky childbirths across the globe and across all cultures. While there will always be the potential for maternal deaths, these rates should not be as high as they are, nationally or globally. In a statistical sense, only about 5% of all pregnancies should end in maternal death. This is just a little higher than the probability of dying from a cavity that you don't take care of. In addition, there are some very clear underlying causes of maternal death, and most of these are often the result of medically approved interventions or institutional structural violence that put parturents at high risk for maternal complications, death, or neonatal death. Further, when I started this research 20 some odd years ago, obstructed labor was counted as 8% of deaths globally. But as you can see here, obstructed labors aren't even counted. So there seems to be a loss of the too small pelvis. But there's still an issue we need to think about more deeply. What is putting parturient bodies at risk and making such high rates of maternal mortality a reality today? Who is in most danger of maternal death? Today, there's a new obstetrical dilemma, one that is framed within the white colonial cultural narrative of risk, which has become the universal story of birth, and one that sees only a medicalized body, not culpability of a system, a one-size-fits-all system, but whose size? A critical white feminist lens, broadly defined, is an anti-racist transformation of white feminist theory to be used to expand the scope of feminist thought to critically consider whiteness and its privileges by blending aspects of critical white studies and feminist theory to examine power relationships through an intersectional lens. As white anthropologists and feminists exploring the power relationships of the Victorian era to uncover ways in which science and social performance, class and identity intersect to construct the normal white female body is to engage a critical white feminist lens. However, the very act of examining Victorian era norms is a form of structural violence. But research such as mine, I hope, shines a light on these racist and privileged frameworks and offers an opportunity to rethink how bodies have become defined as normal or deviant, and how these determinations have been accepted without questioning By not questioning the role of the cultural performance of gender against a backdrop of race means we reproduce antiquated ideas of which bodies are valued versus which ones are not. A critical white feminist lens requires us to address the interconnectivity of racial and gender privilege and oppression. Victorian era construction of the proper and appropriate female is at the center of rethinking what it is meant when female bodies are privileged or more marginalized. So in summary of what I have presented here and thinking forward to engaging a critical white feminist lens, corset use alongside high rates of rickets in a time of social constraints on females served to disable the white female body, while also amplifying what was seen as deviance in the form of mobility and resilience of non-white female bodies. This dramatically different set of behaviors, so weak and sick versus strong and healthy, as highlighted in Sojourner's Truth's speech from 1851 on this slide, serves to enable systems of oppression and violence and supported sexist and racist narratives within science and anthropological discourses on human variation and difference. In the case of female bodies, white females were seen as more evolved and therefore privileged. But we need to understand who is scripting this narrative and to what end this narrative continues to be reproduced as truth. The challenge in engaging critical white feminist model of inquiry means that as a white feminist scholar, I need to grapple with the ways in which the normal white female evolved. I need to consider my own positionality as a female anthropologist and researcher, and who has reproduced these same ideas instead of disrupting them. By failing to recognize how white Euro-American centric historic essentializing of race was girded by white females who participated and enforced white supremacist ideas is to ignore the privilege that comes with being a white woman. It is to ignore the role in shaping how I read bodies with these scripted norms, and it is to ignore that this further marginalization of females of color is deviant and devalued. My challenge here is to disrupt and rethink the historical race science and subsequent racial underpinnings that persist today by unpacking whiteness and then looking closely at how these practices become visible in their influences, yet remain invisible because we are not interrogating them. Science and anthropological inquiry cannot be absolved of their roles in othering while protecting white female bodies. We need to recognize that medicine has a culture of its own, one built on oppression, one that needs to be rethought, and the evidence needs to include the lived experience as well as the cultural frameworks that people bring with them. A critical white feminist lens requires the rethinking of power relationships and the consideration of the intersectionality of lived experiences. Whiteness should be understood here as an invisible and influential racial category with implications of power, dominance, and normativity. Because the causes and effects of whiteness are rarely explored, the work of critical white theorists is necessary for understanding the hidden mechanisms and dynamics of our racialized society. So why doesn't obstetrics seem to be able to go beyond the medicalized body today? Is it because neither can the people who are happily accessing the system, performing the expectations of the state, engaging in the medicalization of childbirth, scheduling their C-sections and not waiting for labor? Is it because the fear of pain in childbirth requires a medical-centered experience, as does the deep-seated fear of death in childbirth? As I have argued here, the process of childbirth is deeply rooted in colonial frameworks of a racialized science, and that is invisible because we have brought into the idea that childbirth is risky without considering what's at the roots of the risk. As I grapple with risk narratives and their cultural constructions and begin to see how they were produced and now reproduced, a reproductive framework that is unjust, one that values white bodies, one that offers a single narrative, I have to consider how my role and positionality as a white woman and an anthropologist engages in disrupting this. By failing to recognize how white supremacy and privilege comes with being a white cisgendered heterosexual woman when giving birth, I'm failing to actually change the system and to disrupt it. In conclusion, it is from this perspective that I've been shifting away from the exploration of childbirth and risk narratives. It is through this engaged, critical, white feminist model of inquiry that I'm now re-examining and rethinking the ways in which obstetrics, medicine, anthropology all have privileged the white female reproductive body. This requires me to consider more nuanced constructions of risky childbirth narratives, but it also requires that I consider how white masculinist framings of biomedicine were constructed to support white females and subsequently reinforce the marginalization of bodies that are not white. And it opens the door to see the ways in which white females have participated in and been protected by science. My focus here serves to amplify only one aspect of how performance of beauty can be deeply rooted and associated with colonial racialized science that shaped narratives that continue to inform the way in which all females across the globe are measured. This historic framing has become implicit in the idea that females are weaker, less able, and problematized by their body. In addition, as physical anthropologists, it's very evident that white female bodies are missing from our research collections. It is from this perspective that I've also been shifting my explorations of females in the past, looking for opportunities to study, to measure, and explore white middle and upper class female skeletons, as these bodies are often not curated or collected, or even in anatomical collections. So this task is really a bit harder than it sounds, and I'm welcome to hear if anyone has any ideas for me. In the end, we need to consider how our bodies reflect the social boundaries and cultural norms that impact how individuals succeed in the socio-political arena. In the case of risk narratives in childbirth, it is clear that the white elite have been the architects of risky childbirth narratives. What I hope that has become evident as I've tried to unpack the ways in which female bodies are read is that researchers consistently reproduce the white female body as the universal transcript, and that we need to be reminded that science can simultaneously reinforce and be molded by prejudice and serve as an individual and invisible and influential framework in universalizing the idea of normal. My journey here has just started, and I hope by engaging critical white feminist lens, I will shed light on the way to rethink the power relations of white females in the reinforcement of childbirth as a practice of control over reproductive bodies. I also hope by magnifying the lens on childbirth, culturally constructed risk narratives, which have been offered for over 2 centuries as a biological fact, a fact that has diminished all understandings of the dynamic nature of birth process and the range of variability within reproductive processes across cultures, also hopes to magnify the flaws in the system. So I was going to end here, but I can't, because over the past few weeks, the case of Gabby Petito has gained national attention. As many of you may know, she's not the first or the last person to disappear. And for those not following, her body was found. But the question has come up countless times in my mind and in my own newsfeed: why is she getting so much attention? I'm not sure what I want to say exactly, except this whole case and its publicity has brought me back to the heart of my talk, which is the need for us to recognize the privilege of being white women, or for me to recognize the privilege of being white women and how white women are a protected class, and that their disappearance becomes a national discussion. I want to end here thinking about all the non-white women who have disappeared, who are missing, who are found dead across the United States. And I also want to take a moment to remember all the non-white women who have died needlessly in childbirth because of a system that is inflexible to their needs.
Okay, thank you, Pam. If you want to unshare your PowerPoints, we can see people in the gallery. Everybody's unmuted, so if you have questions, please feel free to. I don't see anything in the chat. I don't know, Peter, if you have anything from the live audience. But if anyone has a question, go ahead and call it out. Liam.
Pam, that was brilliant. I love that. It was so good. I mean, this is where things are headed. So my question, I just loved it, Pam.
Thank you.
Okay, my question though is, do you think, given what you call white critical feminism, how deeply entrenched it really is kind of in this colonial, right? Can we use the watchmaker's tools, right? I mean, if we go in those terms, or we do we as feminists, or do we need to rethink kind of, I like how you separate white, right? Just kind of a broader view of that you have. I'm sure you've thought about that, kind of your thinking on that, whether we can do it with the tools that we have.
Oh, I think that's a great question. I'm not sure because I think, by the call to action by McFadden and a couple others, for women, white women in particular, to take on the task, the burden, not to put the burden on others, but to really, really turn the tables on themselves. But I'm not sure. I'm not sure we have the tools to do that because I think we've been white women. We've been so protected for so long, and we've just assumed. I mean, and childbirth is a great place to look because the natural childbirth movement was a white woman's movement. If you really, a white feminist women's movement, and again, I think I don't know. I mean, it's again, I'm on my like I got hit in the face with this like in the last few years, and I was working with oh my God, why am I Loretta Ross and I worked together for a year at Hampshire College, and so that was about 4 years ago, and this is where I started to go, oh my gosh, I am missing this whole thing, and that white feminists, have really sort of hidden or taken control, but not looked at how much their power has problematized others. So again, I think we're working on it. But we're not doing a good job.
And just to follow up, how
Yeah.
much anthropology is, I was just reading a great article on that. I'll send it if you want. How much
Yeah.
anthropology just does not want to deal with its racial misogynist roots, right? Like there's just this denial of that in such a strong way. So terrific, terrific talk. Thank you.
Thanks.
I'm going to put in a question that's in the chat line. So Pam, there's much variation in C-section rates within the US, especially across different states and internationally. Do you see any parallels between the historic concepts you've noted and arguments for pelvic measurements constraints with a need for C-sections?
So that's a multi-layered question. The first part of that question is, I'm going to go with the end to the forward. So no, there are pelvic wise, it's very uncommon to have a pelvis that doesn't measure up. But if you're lying on your back, or if you've been given a cascade of drugs, there are reasons for C-sections, or if the baby's lying transverse, that's definitely a reason for a C-section. But also risk management in hospitals is a reason for C-section. The reason the rates are complicated because once you have a C-section, you're pretty much pushed into having a C-section. So in the United States, when you look at the C-section rates, it's actually first, second, third, fourth C-sections. If you just look at primary C-sections, that's how you do it, but they lump them all together and we end up looking like we do have a crazy C-section rate because you can't go back once you start. Globally, it's all about ease for the doctors because they can get women in and get them out and they don't have to deal. And honestly, in many places globally, it's because they don't want to listen to the women going through labor, or there isn't enough resources to have the women in the spaces while they're having labor. So C-section them in and C-section them out is a much easier and quicker way to do it.
There was one more in the chat, and then I'll come back to the audience. If corset wearing contributes to flattened pelvises, as seen in the Victoria era, mainly England, what would you say accounts for the lack of flattened pelvises in other places where corsets were also worn?
Well, so I focus in on the Victorian period, but it's probably you didn't have, we didn't see flattened pelvises in most places, but the reason why you get this high incidence is because of rickets during the time. So you have a confluence of health issues that make it really the perfect environment to really mess up your pelvis and to die. And that's where the standards get set, where obstetrics is being built is in this time frame in Europe mostly. So and remember, the Industrial Revolution is not just in Great Britain, it's throughout Europe. So we're looking at this around that period of time. But in other places, like in the United States, I don't think we're not having the same pollution and the same high rates of rickets. So you're still corset wearing, but also women are not as, unless you're deep in the cities, you have to have a little more breathing room because you're moving around a lot more too, like in rural centers. Did that sort of answer it? I got a little bumbled.
So any questions from, yeah, Dan, go.
Yeah, hi Pam. Thanks so much for that really stimulating talk. Gave me a lot to think about. I think my question as a DOHAD person, sort of on the one hand, I see the issue of, the first half of your talk, which is really about obstetrics and about, the obstetric dilemma and obstructed labor, and you make a very interesting and compelling case with respect to rickets and corset wearing and so forth. When you shift in the second half to talk about, where maternal mortality and neonatal mortality are today, particularly among women of color, that I'm interested to hear your take on how obstetrics plays a role here. Because when I look at that, when I look at those numbers from a DOHAD perspective, what I see is you have these astronomically high rates of maternal and neonatal mortality because of developmental factors, which of course oppressed people are much more likely to suffer from, right? So you have preeclampsia, you have gestational diabetes, you have macrosomia, you have all of these risks that women of color face, but that don't necessarily have to do with the same sort of obstetric violence that you were talking about earlier, but nevertheless sort of play into this risk around childbirth. So I'm just wondering how you think about these developmental issues in conjunction with the purely obstetric approach.
Oh, that's volume 2. But actually, I do think that there's a new obstetric dilemma, and some of my other colleagues are talking about this, which is around all the things you name, primarily racism and stress, and the impact. And of course, then there's all these other conflated issues, around access to care and things like that. But there is an element of obstetric violence here too, because predominantly when folks of color go in to give birth, or non-binary folks go in to give birth, the ways in which they're managed in the system is far different often than the way white women, who might be of all the same socioeconomic status and everything else, are managed. So there's an entrenched obstetric violence things of violence going on for people that aren't white women. And then there's this second obstetrical dilemma, which is about all these comorbid things that are going on in our bodies, and that's a global thing. And the racism and stress around birthing bodies is a United States thing, but there's still a class issue going on too. And obviously there's some really good research on that as well, which I mean, that's sort of like part 2. If I was to do the next piece of this, would be to really dig into that. But what I'm trying to do right now is just really unpack where white women are in this, so that then we can begin to talk about those other things with some more clarity and maybe disrupt them too, especially as a white female doing that work.
Right. Thank you. Thank you.
Other questions, anyone? So Pam, I was going to ask, so for those of us, I'm not teaching intro to biological anthropology much anymore, but I think the obstetrical dilemma was so deeply part of the narrative when we taught that to all our intro students, that bipedalism placed all these selective factors on the pelvis, and then the pelvis got smaller and upright and more narrow, and then this big brain baby, and it was like a 1-to-1 fit, and if anything was off, that baby was not going to come out. And that there were quotes, at least in the older textbooks that I used when I was in grad school, and maybe even as much as 10 years ago, saying something like that: probably birth killed more Homo sapien women than any other thing. So that's so embedded in the literature. I mean, and I know Holly Dunsworth has countered that with a lot of research that she's been doing, but she's also taken a lot of flack and gotten a lot of criticism. So where do you see this going in terms of how we teach our students about the evolution of bipedalism without sort of then relying on this notion of the pelvis and the baby's head being like now this critical juncture?
Well, I mean, I do think, that the idea that we're big brained plays a big role in, like, we have these shorter gestational periods and longer altricial periods, you know, and things like that. But the reality is that it's the language of evolutionary and a little archaeology and bioarchaeology is to devalue female bodies. I mean, that's essentially what it's doing. So it's so easy to say, oh yeah, they must die, because they really don't have much agency otherwise, because then it plays into all those other things about their role in community and their role in society and what other things are they doing besides being pregnant and in the kitchen. And I mean, I've talked about this for years, but I think we have to rethink it. And I think it goes back to Liam's point that there's a resistance to rethink any of these things because these are so entrenched and so deeply rooted, and that it is, and it was a way to really devalue, when we only had males and females too, to devalue females within this evolutionary structure. And I mean, there's a lot more about how female bodies are devalued throughout the whole of, like, looking at the whole skeletal body and in the evolutionary studies world. So I think that it's time to rethink how we teach that, basically, and to rethink. I mean, it's the same thing, and I'm going to say it, and hopefully everyone hears this, but you can't tell how many pregnancies a person has had based on looking at their pelvis. And yet I'm still reviewing articles that are like, well, they had so many babies because we look at the parturition score marks here. And I'm like, that's not possible. We don't do that. We can't do that. You know, we can't even tell if somebody gave birth for sure unless there's a baby in utero when we excavate them. And even, you know, there can be some questions around that too. So I just think that there's a lot of unknowns, but one known is that we're really devaluing females in this whole story of human evolution if we keep killing them off because they were pregnant without any truth to it. And I think Holly's work is really important because Holly's work recently has really looked at the physiological ways in which pelvises grow and why female pelvises are bigger than male pelvises beyond, you know, its physiological processes, but it's also about what's inside versus what's on the outside. And there are pressures there. But I would also say the other piece, which I don't go into here, but in other places I do, is birthing positions. You know, lying flat on your back is not the best plan. And with your legs up in the air, it's even worse. And I think hospitals and doctors are starting to recognize that a little bit. But the babies, we don't ever talk about the baby, the neonate, which plays a role and is actually an active participant in the whole birth process. And they squirm and they move and their heads, I don't think many people don't see, the only time you see a really nice round baby head is when it's been a C-section. So really, there's a lot of things going on with that neonate that are meant to help in this whole process too. So, you know, it's a much, I mean, we totally forget about the babies in the whole conversation, which we need to remember they do participate.
Well, I think this is it. So thank you so much, Pam. This was great, and it's lovely to see you. I can't wait to see you this summer. And we will let everyone depart 1 minute early.
Thanks.
Thank you.
Bye.
That was fantastic, Pam. I loved that.